who is an international student from Singapore, my home country as well. She is a third-year UCSF student in the Pharmaceutical Sciences and Pharmacogenomics program, and basically she studies how different communities of gut microbes affect the way our body metabolizes drugs. And every time I speak to her, she has a different story to share. And today she's going to share on the topic of fighting COVID using the power of the tidyverse. So over to you, Janice.
Okay, thank you, Viceman, for the introduction. So clearly, I like clickbait titles. I read a lot of crappy articles, but that's not the point. Okay, so hi, I'm Janice, and yeah, just a fun fact. Actually, today is very aptly World Pharmacist Day as well, and the reason I'm stalling for time is, it's up, great. Yeah, I thought my PowerPoint was gonna crash. Okay, so yeah, so I fought COVID using the power of tidyverse. Yeah, so the actual title is connecting the dots from different square inches of my life. And yeah, so a fun fact is I'm actually a pharmacist as well, and I'm a graduate student at UCSF in the Turnbuck lab. So I love puns. So this is a PI approved pun, which says that bugs in our gut bug more than our gut. Okay, which means that essentially when the gut microbiome resides in both the small and large intestine. Okay, and a lot of research actually at the moment is trying to look at how the microbiome can actually metabolize drugs. However, what I'm looking at instead is how the gut microbiome can actually influence drug metabolism in the host itself, both through drug clearance as well as drug absorption. So this can actually change your drug profile. So this is what I'm looking at, and I work with a lot of mice and a lot of sequencing data and stuff. So essentially, I'm a nerd. I do both wet lab and dry lab, which is why you can hear my computer running like a jet engine half the time because of computational work. So I do a lot of sequencing and so on. And yeah, so I do like both. So the interesting part is that I do have another background. So I actually graduated my college degree was in Singapore. And in Singapore, you do not need to go to graduate school to become a pharmacist. You can just do it as your undergraduate degree. So I graduated from pharmacy school, and I was a trainee pharmacist at a general hospital in Singapore for about a year. And around the same time, I was also a volunteer student pharmacist at a community clinic called HealthServe. So now all this seems very strange because there are two things here that are optional, which is one, being a trainee is not needed, because when I actually first got into college, I was already on a research scholarship, which I am still on now, which is called A-STAR. And so they're supposed to fund me for both my undergraduate degree or college degree as well as my PhD. So already at 18, I knew that I was going to do research. So, actually doing clinical research wasn't really, supposed to be my thing, kind of. Especially because I did not only take the time to, do research events. HealthServe is a migrant workers clinic. So in Singapore, migrant workers are people who are usually low-wage workers. They come from other countries, they have very low pay, and they have a lot more barriers of access to healthcare compared to your regular citizen. So we have a community clinic for them to be able to try to give them healthcare and help them with their needs. So I was actually there for a really long time, and I did spend quite a bit of time there. So it honestly feels like it does contradict, and both research as well as clinical practice actually became my passion. So this is actually something I've been struggling with for years and years. Like, God, why do you call me to both? Because I was called to both. Yeah. So, a lot of people, like when I was interviewing for trainee pharmacist positions, actually a lot of people did question me as well because of the A-STAR scholarship. So this was something I've always been grappling with, like, God, why do you call me to both? Yeah. So what happened was, I was struggling with this for so many years, but then what happened was, in 2020, a lot of fun things happened. Like one of it is called COVID-19. Okay, and this is actually the graph. I got it from Google. You can find it for every country. And around Good Friday, actually that was when Singapore started to have a massive COVID outbreak. Before that, it was like less than 2 digits per day. But suddenly, we found out that the migrant workers had a huge outbreak. They were all living in close proximity to one another. And suddenly I was like, oh gosh, what's happening? Yeah. So the numbers were spiking. I was wondering what to do. I actually messaged people back at HealthServe who were my friends, like, hey, how's everything? And then at that point, I was just like, oh, can I pray? And then I was feeling very frustrated because I was in San Francisco. I thought I couldn't go back. And then what happened was I saw this thing called the SG Healthcare Corps, which is actually an initiative by the Singapore government to say that because of the surge, we are going to start asking people who are not currently working in public hospitals, but who are licensed healthcare professionals to come back and work for us to cope with the surge. So it was something like, hey, I suddenly thought about it and I was like, oh, actually, that sounds like me because I'm working in research. I'm not working in a public hospital. I could actually do it. And furthermore, because I have been at HealthServe for so many years, I actually knew what their conditions were like. I knew how to talk to them. And yeah, I was actually very familiar with this patient population. So I grappled with it for a while and I talked to many people. And actually, I think it was really a blessing because at that time, actually, UCSF just closed down. So there was a lot of like struggle with like, oh, we are stacking all our mics, what are we going to do and all that. But actually my PI allowed me to go. And I actually also postponed my course. Yeah, so it was supposed to be my QE and thankfully my committee actually let me postpone it. So I actually took it in July this year. Yeah. So yeah, so I was actually in Singapore from around slightly after Good Friday till around mid-June when the numbers came down greatly. So who are my patients? So most of them are actually low-wage migrant workers. In general, they're on the younger side because they mostly work in the construction industry, and after they hit a certain age, they will go back and start their own businesses in their own countries. Yeah, so a lot of them were actually mild COVID cases who did not require frequent monitoring or interventions. So what I was working at was actually called a community care facility, where it's not like a hospital when the nurses check on you like 3 times a day, but rather you're just there to be isolated so that you don't spread it to your friends or whoever else you live with. However, there was still about 5% of the population who have chronic diseases that need to be managed, and a lot of people who are coming for things like symptomatic relief, so things like all your cold, pain, and all the backaches and like fungal infections that they usually have, like that could have actually started because of their work even before COVID. Yeah, so actually a lot of this occurred because migrant workers have always been living in very cramped living conditions in dormitories, and so actually this has always made the population very vulnerable to many infectious diseases. Yeah, so actually the way they live is a bit more like a summer camp actually, where they have many bunk beds, although it's not as fun as a summer camp. It's like 11 to 12 people in a room. Yeah, that's how it spreads. So I hope this video works. So this is actually where I was working. Okay, this may not be the exact hall, but yeah, so we actually set up a whole Singapore's like #1 place for conventions. And so we all use all the poster boards that we couldn't use for, you know, our conferences to actually set up rooms for them. And yeah, so this was actually the facility I was working at. So it's a massive, massive operation by like a lot of people, not just me. And so that's why they needed to hire people to cope with the surge. Yeah. So this was, yeah, the setup. Oops. Okay. So I was hired on as a part-time pharmacist, or we call it locum. So what we did was, this is essentially a very normal pharmacist job. So I was like, oh, okay, it's time to take a break from, you know, being a grad student and so what I was doing was very simple things. So checking and making dosing recommendations for doctors' prescriptions, ensuring sufficient medication stock and supply, liaising with the store to check that we can supply the medications that are not so commonly supplied. And then we'll have to call the patients and try to teach them, because we are trying to avoid face-to-face contact. So that was a bit tough, but it was cool. However, because this was such a massive operation, there were a lot of problems. Everything was started up very quickly from ground up. A lot of workflows were like created on the fly. So things like, you know, when the patients are brought in from their dormitories, sometimes they barely have anything with them. They just come with the shirts on their back. And they can, once they enter, they cannot go out until they are done with their 21 days of quarantine or isolation. So for patients with things like chronic medications, they can't get it from their dorms. And they also did not have the option to go back to their home countries to seek the medical care that they usually did. So we had to ensure things like topping up their medications for them. And we had to do it for up to 10 weeks because there was also a lot of issue with things like even after the 10 weeks, they have to be housed separately and isolated and all this stuff. There was a lot of stuff going on. And because of the COVID lockdown, there was also a low medication supply around the whole world. Because our usual suppliers were all in lockdown, we actually couldn't get a lot of essential supplies in, even though essential businesses were still supposed to be running. And then there were a lot of things like disjointed medication ordering, and their home countries' prescribing habits were actually really different from ours. So we had to switch medications, explain things to them. And yeah, it was a bit of a nightmare. And then infection control for other non-COVID diseases was also a problem, and language barriers. So there are a lot of things that I realized I couldn't do. And yeah, every day the workflows change. Every day is a surprise, which is, I don't know, fun, I guess. Very normal as a grad student, but not normal as a pharmacist. So however, I realized that to some extent, a lot of the things I was dealing with was just huge amounts of data and many, many Excel sheets from like different systems. So that actually sounds a lot like, you know, something that I've been doing in my research, which is to join many Excel sheets together from different machine outputs. So yeah, I realized that actually I could help a bit with the chronic supply of medication to patients. So I actually use dplyr, which is a subset of a library called the tidyverse, which is an R package, to actually help to streamline workflows. So because of the ever-changing workflows every day, actually the 10-week supply of medication was something that was not decided until like we were a month into operation. So we actually needed to find out who were the patients who were going to be discharged, who needed top up and so on. So essentially I had to do a lot of merging, like 4 humongous Excel sheets, which would have crashed if you did not use a coding language. So which contain a lot of information to be able to filter and tell the doctors we work with, like who are the patients who require top-ups, can you please review them, and then prescribe the medication so we can supply it. And then I also created other scripts such that because previously what we have been doing is the doctors actually need to make the order on the system, and because the system is disjointed, the nurses need to then text us on a secure system to alert us that there was a prescription. So instead, we actually needed to make the life of the nurses easier. We actually said that chronic medications do not need to be texted. I came up with a script to be able to filter that out from the system. And so the nurses only needed to alert us of like issues with like the more urgent medications, like pain medications. Yeah, okay. So yeah, so after all my genius, you know, engineering, software coding, the chief doctor just said, you know, pharmacy has a magic script that told us who needs top-ups. Yeah, it was very well appreciated. And I think the facility is still running, although to a much lower capacity. And yeah, they're still using my scripts, I think. Yeah. So, okay. So, you know, reflecting on all that, I actually kind of realized like, hey, I know what I did. I mean, it's not the biggest of things, but it was really cool because God actually gave me an answer to like the struggle I had, which was that, like, why am I both a clinician and as well as a researcher? And it's a non-answer, but it just made me realize that, you know, even as a researcher, I can still contribute so much, just in a very different and unexpected way. Yeah.